I know your final year exam going students have now finished the theory and they're awaiting the result. And immediately, as we know, within 2 to 3 weeks, we have practical. So, as per all your requests for next 1 to 2 months, I'll concentrate on clinical case presentation, case capsule discussion, Hosky, etc. So, it helps you for your practical. As I always have been telling, there are two cases which are make or break. One is a breast cancer case, another is a oral cancer. Every DNB surgical onco student in his practical exam will mandatory get both the cases. No excuse. All of them will get both the cases. And how you perform in these two are basics. There is no margin of error in these two cases because you're supposed to know in and out of it. That's one of the reasons today we have two cases, early breast cancer and LABC, presented by Rumani and Ashish, two exam going students, and two senior most surgical oncologists, examiners, trainers, both MCH and TNB surgical onco examiner of vast repute, highly respected in our oncology field. Professor Vijaykumar sir, you all know them. He's a teacher of teacher. Almost every teacher is trained under him. After teaching and mentoring many and many students in Kidwai as a professor, HOD director, he's a vice chancellor, and then he is doing fantastic work. Almost everybody knows him in all the conferences you get learned until the second class service taking for us. Very busy, not just a great clinician, he's an administrator, so much whole institution under him. Yet because of his passion to teaching, he has taken the time, and heartfelt thanks from DNB board and myself and students. Then Diptendra Sarkar, senior most professor, has been in teaching of surgical onco, especially breast. He's also been a past president of Association of Breast Surgeons of India. Multiple, very, very high impact factor, original research work on breast from his, if you go on Google. He's also a visiting professor in breast in Mayo Clinic, Rochester. Very busy, but great clinicians, great teachers. Heartfelt thanks for both of you for accepting our invitation. So the way we will do is, initially Rumani will go, she's going to present early breast, then Ashish locally advanced. After both the cases are discussed by two experts, then they will open the Q&A and chat box and try to answer your doubts in the given time. Thank you very much, and over to you, Rumani. You can start.
Okay. Good morning, sir. I would like to start my presentation. The case is early breast cancer. My patient, Mrs. Taslima Khadun, a 43-year-old female resident of Murshidabad, Muslim by religion, homemaker by profession, presented with us to us with a complaint of a lump in the right breast since 3 months. Patient was apparently all right 3 months back.
Rumani, can you
Yes,
open
sir.
your video when you present?
So I think
the video will not work. She is using the iPad.
Yes, sir. So should I proceed, sir?
Yeah, go ahead.
Patient was apparently all right 3 months back when she noticed a lump in the right breast while bathing. Located just below the nipple, was initially small to begin with, of approximately 1 centimeter in size, and gradually progressed to the current size of 4 centimeter. There was no pain associated with lump or ulcer over the lump, no history of nipple discharge, no swelling in the armpits or the opposite armpit, no history of swelling or heaviness in the arm, no history or suggestive of low backache, bone pain, chest pain, cough, hemoptysis, dyspnea, or headache. No history of any breast disease or breast surgery in the past. There is no history of connective tissue disorder or no history of any chest radiation in the childhood or any surgical medical history in the past. On personal history, she is married for 25 years, consumes mixed diet, no history of any addictions. Patient's bowel bladder habits are normal and her sleep is normal. There is no history of loss of appetite or any allergy to drugs or food products. Her menstrual and reproductive history is as follows. Patient attained her menarche at 13 years of age. Her cycles are regular with a cycle duration of 30 days. And she experiences menses, menstrual, her menses for 4 days. Obstetric history, she has a history of 2 live childbirth, G2, P2, L2, A0, D0. The age at first childbirth was 22 years, and the average duration of breastfeeding was 2 years for both the children. There's no known hereditary history or hereditary disease in the family. There is no history of breast, ovarian, colonic, stomach, or prostate cancer in the first or second degree relatives. So, should I proceed or should I summarize my history?
Would you like to summarize your history, Dr. Ramani?
Yes, sir. 43-year-old female presented with premenopausal 43-year-old female presented with complaints of right breast lump, which was gradually progressively increasing in size with no pain.
Hello.
Hello.
Yeah.
Yes,
Continue.
sir.
Continue.
Okay, sir. On general physical examination, I examined the patient in broad daylight after obtaining verbal consent and after adequate exposure. Patient was conscious, oriented to time, place, and person. Her ECOG performance status was 1. She was of average build and her BMI was 28 kg per meter square. Rest of the general physical examination was essentially normal, including the neck nodes, supraclavicular nodes, and there was no other obvious deformity. The spine was normal.
1 second. 1 second.
Yes.
I missed you are moving to physical examination.
Yes, sir.
In the history,
Yes,
you
sir.
spoke so much in detail about the gynec history. How is it relevant? I'm not talking about obstetric history.
Yes, sir. The menstrual history, sir. The age of menarche, early menarche and late menopause is contributory to breast cancer, sir.
How do you explain that?
Sir,
what is the hypothesis behind that? Early menarche and late menopause. What
sir,
is the hypothesis?
prolonged exposure to estrogen, sir, which is implicated in breast cancer.
Prolonged exposure to estrogen. Okay.
Yes, sir.
How the first childbirth comes into the picture?
Sir, first childbirth after 35 years of age carries a risk of increased risk of breast cancer, sir.
Repeat what you said.
More than 35 years of age, sir.
35 years.
Yeah.
Yeah. You said about you're not written, somebody is asking.
Yes, sir.
The first pregnancy, if it has occurred before 30 or before, say, here it is 22.
Yes, sir.
Whereas the first full term pregnancy occurs at 35. I'm just giving a situation.
Yes,
Which
sir.
is more important now for you?
Sorry, sir, I actually did not get the question, sir. 35 years of age she attained.
No, what I mean is
Yes,
the age at which pregnancy and miscarriage, that is important.
Yes, sir.
Or age at which full term pregnancy is important. That's what I'm asking.
Sir, age at which the first full-term pregnancy occurred.
How do you explain that?
Sir, because the period for estrogenic stimulus, sir, it is less in case of full-term pregnancy because of more of progesterone, less of estrogenic stimulus, sir.
Okay. In the age of menarche,
Yes, sir.
can you explain?
So, if it is early age of menarche, is if the patient has attained menarche less than 12 years of age, sir, before 12 years of age.
No. How do we explain? I'm asking. Early menarche and late menopause is going to
Yes,
have
sir.
problem, and for that the duration of estrogen exposure you said.
Yes, sir. Yes,
that
sir.
is one issue.
Yes,
Now
sir.
I'm asking early menarche. What out of the two I'm taking up early menarche and asking how to explain what is the basis they are claiming to say that has got an impact. That's all I'm asking.
Sir, early exposure and prolonged exposure to estrogen, sir.
No. Early exposure, prolonged exposure, you already explained. Anything else?
Yes, sir.
Anything else I asked?
No, sir.
Anything else I'm asking?
No, sir. I am not able to recollect, sir.
Yeah. See in the menarche time.
Yes, sir.
They are expected to have more of anovulatory cycles.
Yes, sir. Yes, sir.
And anovulatory cycles means there is no progesterone.
Yes, sir.
So the theory is unopposed action of estrogen in the early stages of breast development.
Yes, sir.
Breast was rudimentary till that time. During menarche, the breast will start budding, right?
Yes, sir.
So at that time, the action of unopposed action of the estrogen. That is the theory.
Yes, sir.
Anyway, you have said now the basis hypothesis correctly.
Yes, sir.
How much of evidence we have got in all this?
So I am not aware, sir.
Are you catching my question at least?
Yes, sir. Yes, I am.
That whatever you said, I said is all basis, that's why we are taking this history and in detail we are going. So I am just asking. These are all hypotheses.
Yes, sir.
And at least in any cohorts or anywhere it has been proved, or we are still continuing with our hypothesis and taking the history that way.
Yes, sir. Sir, I am unaware of the this trials or evidence backing it, sir. Orthodox trial or sorry, Oxford trial or I'm not really sure, sir.
Right. Dr. Sarkar, you can help her?
Yeah, I mean, as Sir has rightly told you, that uh, the the explanations are hypothetical,
Yes,
but
sir.
it is all are backed by solid evidences.
Yes, sir.
The only thing that you need to understand that the rules that are applied that you see, I mean, related to menarche, to obstetric history, to childbirth, the duration of lactation, these mostly follow the luminal pattern of cancers. Okay,
Yes,
whereas
sir.
in triple negative breast cancer, these rules are weaker. The relative risk is strong in favor of luminal cancers, and these are accepted risk factors. Breastfeeding in triple negative breast cancer, parity in triple negative breast cancer does not have any reduction of relative risk. Okay.
Yes, sir.
Please continue, ma'am. Continue with your physical facts.
Sir, sir, if you just allow me one, two
Please
questions.
go ahead, Dr. Sarkar.
Yeah. Now, Rumani,
Yes, sir.
what do you understand by a familial and what do you understand an hereditary breast cancer?
Sir, familial is where there is no genetic mutation associated, and inherited is where genetic mutation is associated. There's unnatural cluster of cases with no genetic alteration in hereditary disease, sir. And in case of familial, there's unnatural cases clustered with no genetic alteration, no known genetic alteration, sir.
Very good. So, if I just summarize it, you make it very clear that there is unnatural clustering of cases, yet, as of now, we are unable to identify the genes. But I'm sure the number of familial breast cancers are going to reduce and they will go into the hereditary component as time goes on. Okay?
Yes, sir.
Okay, so you can continue with the physical examination.
The patient is asked to sit and both the breasts examined with the arms by the side, the arms raised above the head, with the hands placed in the waist and in the leaning forward position. In the arms by the side, the right nipple appears to be retracted. There is no change in the position and with no fissuring or any discharge seen. The right areola appears to be normal and it is not displaced with no ulcer or any eczema over. There is a fullness noted in the inferior quadrant of the right breast, which is situated just below the nipple, sir. There is no evidence of any scars or engorged veins or pigmentation or any redness or any skin dimpling or ulceration or nodules or pure orange appearance. Both the arms show no evidence of any edema, sir. Um, on leaning forward, both the breasts fall equally both the breasts fall equally, sir. And with the arms raised over the head, the right nipple appears to be more flattened and retracted, with nipple areolar complex shows to be pulled down in comparison to the left breast, sir. There's fullness noted in the lower quadrant below the nipple of the right breast. With the arms and the waist, the retraction of the nipple becomes more evident, sir, and the fullness a little more prominent, sir.
Okay. Sir, would you like to ask questions on inspection or we go straight?
No, not really. Let her complete the physical examination. Together, I thought I'll take physical exam, total. Physical.
Okay, sir. On palpation, both the breasts were palpated in sitting and recumbent position. Breast size was 38C and tosses of grade 3, not 2. Palpation of the left breast was normal.
One second, go back. Because this part now has entered into, because of the breast surgery being done and breast surgery coming out.
Yes, sir.
Separately, the second part I'm telling. For the
Yes,
benefit of people who may or may not know, I'm asking this question. You already pointed out, but will you tell me what is this ptosis grading?
So it is.
And also what is the 38C you are talking about? Okay.
Okay, sir.
Yeah.
So the 38C is 38 is the circumferential diameter, sir, of the chest wall at the level of the breast, and C is the cup size, sir. And ptosis grade, it is on the basis of the nipple-areola complex at the level of the inframammary crease, sir. If it is 1 centimeter below the inframammary crease, grade 1. If it is 2 centimeter, it is grade 2. And if it's 3 centimeter below, it is grade 3, sir.
Fine, proceed.
Dr. Rumani, sir,
Yes, sir.
just a small clarification.
Yes, sir.
Now, you told it's cup C. How to measure cup C?
Yeah.
That's the question.
Sir, I can ask her what brassiere size does she use, sir. So she would be.
That's not. That's not the way to ask. There is a way to measure 38 and measure C. We are asking you how do you measure 38 and how do you measure C?
Sir, I am unaware, sir.
Okay, so if you are measuring the 38, that's the circumferential measurement of the chest wall.
Chest wall, yes, sir.
At the level of nipple areola complex.
Yes,
okay?
sir. Yes, sir.
And the next measurement that you take is at the inframammary crease level. Okay?
Sir. Yes, sir.
So now you subtract the chest wall diameter of neck versus minus the chest wall diameter at the inframammary crease.
Okay, sir. Yes, sir.
So if it's 1 inch, then B. It's 2 inch, it's C. If 3 inches, D. Like that, it goes on. Okay.
Oh, yes, sir. Yes, sir.
So if you, it's 38. That means it's 38 inches, and C means at least there is a difference of 3 inches between the two. Do you get my point?
Yes, I do. Yes, sir.
Of the two, cup size is far more important than the bust size. Clear?
Yes, sir. Yes, sir.
Okay, thank you. You can proceed.
So, proceeding with the palpation of the breast, right breast, temperature was equal in all the quadrants. There is no tenderness. A 2.5 or 3 centimeter lump at 6 o'clock position of the right breast, just below the nipple, which was irregular, having an irregular surface with ill-defined margins. Hard consistency. It was not fixed to the skin or chest wall, sir. There were no palpable lymph nodes in the axilla, in both the axilla, sir. And the systemic examination was within normal limits, sir.
You won't comment on supraclavicular separately as you commented on axilla?
Sir, I commented on the supraclavicular lymph node examination, the general physical examination. Mentioning.
No. I am specifically
in this. Yes, sir. I would definitely.
In the breast examination, when you have got a lump, see, then why do you talk about axilla? That to both axilla here. You would have told, I have said it in the physical examination. There is no generalized lymphadenopathy.
Yes, sir.
Correct?
Yes, sir. Sorry.
When you have said it in the generalized examination, no lymphadenopathy, we got it.
Yes, sir. Okay,
but
sir.
when you are coming to breast examination, it is probably mandatory to tell exactly what is happening to the regional group of nodes.
Sure, sir. Sure.
In that context, you are talking axilla, so you talk about supraclavicular also.
Yes, sir.
Right?
Yes, sir. Sorry,
so
sir.
Even if you have said there, no question of meaning and all. You are in the examination, you should be pressing certain points, probably if necessary again, right?
Yes, sir.
Because if supraclavicular, even if it is negative, it's an important finding you have to bring.
Yes, sir.
Will it change the staging or not?
Yes, sir.
Can you have a node in the supraclavicular region without axillary node?
Sir, it is highly unlikely. Axillary nodes
can
are
we
usually.
Have? What's the question? How?
No, sir. No, sir. No, sir.
You cannot have.
No, sir.
You cannot have. Huh?
Yes,
it is
sir.
the the disease will go according to our laws.
Yes, sir.
Huh?
No, sir, no. It,
Dr. Sarkar, you can comment.
Yeah, sir. I agree with completely with sir. Okay.
See, the point here is, it's not a step-ladderly pattern, right?
yes,
That
sir.
it has to go to level 1, then only to level 2, then level 3, then infraclavicular, then supraclavicular. Is that way you think it is going?
No, sir. It is not necessary, sir. Not here. Not here, sir.
That is the point we are talking, okay?
Yeah, yeah.
That it can be very unlikely or less likely and all is true. But in a clinical examination, you are mandated to examine what are the regional nodes and then come out. Suppose if you had examined the supraclavicular and at least you are told that you examined, these many questions would not have come. All
Yes,
right?
sir. Yes, sir.
Right. Thank you. Please proceed.
Okay. Now, as sir has told you, now as examiners actually look at points which has to, these are like tick boxes in the brain of the examiner. They will are looking forward to whether you have mentioned these points or not. Okay.
Yes.
So
Yes,
be
sir.
very careful about this. You told
Yes.
about the 5 different positions of inspection. Now,
Yes,
can
sir.
you tell us what is the need of asking the patient to elevate the arms?
Sir, to elevate the arms, the if there is any skin dimpling or retraction will become more prominent, sir. Also, the inframammary crease will be seen, sir. And also, sir, if there's an occult, it helps in manifesting an occult lesion, sir.
Very good. So the answer is manifestation of occult involvement and inframammary crease.
Yes, sir.
What is the role of asking the patient to stoop forward?
The role of asking the patient to stoop forward is to see if the tumor is fixed to the chest wall, sir. If the tumor is fixed to the chest wall, the opposite breast, the diseased breast would not fall forward as much as the opposite breast, sir.
What is the role of asking the patient to tighten on the waist and then relaxing it?
Sir, again to check for the fixity of the tumor to the pectoralis muscle, sir.
How would you on palpation ascertain whether the lump is fixed to the breast tissue?
Sir, if the lump is fixed to the breast tissue, it will move with the breast tissue, breast parenchyma. On moving the breast parenchyma, the lump will move with the breast parenchyma, sir.
So how would you do that? How would you test that clinically?
So, by holding the lump and then moving it sideways like a pendulum, sir.
No, first of all, you must hold the breast beneath.
Sorry, yes, sir.
The breast goes into inertia of rest, and then you make the movement in both axes. Okay.
Yes, sir. Yes, sir. Yes, sir.
How would you test for fixity to the underlying structure?
Sir, fixity to the underlying structure, sir. The breast would not be mobile even with hands. The lump would not be mobile with even with the hands at rest, sir. Or
Okay.
even with tauting the pectoralis muscle, or not tauting the pectoralis major muscle, sir.
What is the implication of fixity to serratus anterior and implication of fixity to pectoralis major?
So implications of fixity to pectoralis major does not it does not imply T4A lesions, sir, to pectoralis major. Whereas
No. That's not the way, man. You have to tell it doesn't change the T status. You're right. I'm only
Sorry,
modifying your answer. It doesn't change the T status.
okay, sir. It does not change,
Yeah,
with the
it doesn't
involvement of
change the T
yes, sir.
Correct. I have a question
Yes, sir.
in continuation with what Dr. Sarkar is asking, because we talked about serratus anterior, we talked about pectoralis major.
Yes, sir.
Clinically, can you make out pectoralis fascia involvement?
Pectoralis fascia involvements are the lump would, sir, become so I'm not sure, sir. I'm
See,
not sure,
for
sir.
pectoralis major, any muscle, and here we are talking pectoralis major muscle. You
Yes,
will
sir.
put them under contraction. Okay?
Yes, sir. Yes, sir.
That's how you are going to find out whether it is fixed to the muscle.
Muscle.
Or
Yes, sir.
now, with respect to pectoralis fascia,
Yes, sir.
any guesses? Anyway, you said don't know, but guessing? Any guesses?
So it would be if it is involving the pectoralis fascia, even if we make the muscle taut, the lesion
No,
would
no,
be.
no, 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 no. See,
Mm.
muscle, with respect to muscle anywhere, before and after contracting, you have to check to know whether it is involved. Correct?
Yes, sir. Yes, sir.
Whereas in fascia, you have to stretch the fascia to know before
If
and
it's-
after stretching the fascia, you have to know whether it is involved or not.
Yes, sir.
So that means, how do you stretch the fascia here, pectoralis fascia? What do you do? What maneuver will ask the patient to do to know whether a pectoralis fascia involvement is there or not?
So we can ask the patient to abduct the arm, sir, at
No,
90-degree.
no. It has to
No.
be stretched like this. Can you see me?
So
Stretch
no.
like this. Okay.
Okay, sir.
When you do that, it is stretching. So, in
Mhm.
other words, fascia involvement you will
Mhm.
try to identify by doing stretching of that fascia. Muscle involvement you identify by making contracting the muscle. You
Yes,
follow
sir.
me?
Yes, sir. I do.
How far it will be able to do that will be most important issue. That is
Yes.
different. But just because the staging, now I have a different question as a treating person.
Yes,
How
sir.
does it matter when the T status is not going to change when pectoralis major is involved or fascia is involved? Then why do you do all that?
Sir, to assess for the post-op morbidity associated with it, sir.
What post-op morbidity? You are not going to operate on that patient, for example.
Yes, sir.
That time it will not matter.
Yes, sir.
It will matter for a surgical procedure.
Sir. Yes, sir.
When you have identified the pectoralis major is involved, let us imagine.
Yes, sir.
Will you leave that and come? That part
No,
of
sir. No, sir. We'll reject it,
why
sir.
I said it is the T status it may not change, and hence that is you may think it is irrelevant. Pectoralis
Yes,
major
sir.
is involved or not.
Yes, sir.
But yes, when it comes to surgical management, it definitely matters when you go in because you will get the cut margin positivity.
Positivity, yes, sir.
Right?
Yes, sir.
And
Yes, sir.
also will be cut in pectoralis major is involved. Let us imagine.
Yes,
You
sir.
will actually cut through the tumor. It's not microscopic involved.
Yes, sir.
In exaggerated way I'm talking. Okay?
Yes, sir. Yes.
So that is important to know whether pectoralis is involved or not.
Yes, sir.
If it is involved, it's a surgical question. You may have to remove the whole pectoralis major.
No, sir.
Uh,
Just area infiltrating the pectoralis major with good adequate margin, sir.
Correct. We are not, you need not remove the whole muscle. Wherever it is involved, if you can give a clearance there and that area alone, if you remove, that is good. All right.
Yes, sir.
Coming back, we continue, please.
Again, Iman,
Yes, sir.
the next question is how would you identify or clinically examine for the infraclavicular group of nodes? Because that's part of the AJCC now. So, how do you examine the infraclavicular nodes?
Sir, for infraclavicular nodes, there'd be fullness in the infraclavicular fossa region. And on examination, sir, by bidigital examination, the groove, bicipital groove, sir, um,
Is it the
deltopectoral
bicep?
groove, sir, deltopectoral groove, sir, there'd be presence of nodes.
So, where exactly your fingers are going to go? You towards a bidigital or bimanual palpation.
Yes, sir.
So, where will be your fingers or your palm faced?
Sir, one of my with bidigital, I would use one finger within the one palm in the axilla behind the posterior anti-axillary fold, and one in the this deltopectoral groove in the infraclavicular fossa region, sir.
Very good. Very good. You can proceed.
That
Uh,
takes me to the next question. Actually,
Yes, sir.
Dr. Sarkar has put this question into my mouth. You have to blame him.
Yes,
How do you differentiate an axillary node
yes, sir.
from the tail of the breast?
Actually, note from the tail of the breast, sir. Uh, Sir, it would be behind the anti-axillary fold.
Where will the tail be?
And
Tail of Spence.
Spencer, sir.
Yeah.
Yeah.
How do you,
Behind.
how do you differentiate? This becomes important where you tell me. In which condition you will think this is important question.
So to rule out if there's a discrepancy with the occult axillary metastasis and not able to find the primary lesion.
Yeah. In other words, breast examination is otherwise normal.
Except yes, sir.
And there is a lump there in that area. Now, you think it is a node.
Yes, sir.
You do an FNSC, for example.
Yes, sir.
They say breast duct cell C.
Yes, sir.
Now, how do you differentiate whether it is a metastatic node duct cell C or whether it is tail of the breast where probably a fibroadenoma is sitting there? How do you differentiate? This place only will have problem.
Yes.
If there is a breast lump already, as in this case,
Yes,
and
sir.
then you go and see something there, you
Yes,
will
sir.
presume, you will not even, it will be a cursory examination will do and say it is a lymph node. But
Yes.
when, otherwise the breast is normal, there is only one lump that is sitting there in the area which we are talking now. So to differentiate the lymph node from the tail of breast becomes mandatory.
Yes, sir.
So what is the test we are expected to do is whether it's mobile or not, that's one.
Yes,
And
sir.
when you try to pull it, the nipple areolar complex should get pulled towards the
So again, yes, sir.
If you do that, we presume, on clinically speaking, we presume that it is a part of the breast.
Yes, sir.
Whereas if it doesn't happen, you will think it is probably a lymph. This
Yes.
is a clinical sign. You know clinical signs,
Yes, sir.
right?
Yes.
So it's only a clinical sign. But because we talked about infraclavicular in detail, we are talking about other areas. So I thought, as a part of education, I am saying that not that it is going to be a regular or very often we are not going to have this problem, but
Yes, sir.
for the knowledge purpose, I said.
I would like to summarize my case, sir. 43 years old, premenopausal lady presented with complaints of painless, progressively increasing lump in right breast for 3 months. On examination, a 2.5 by 3 centimeter lump noted at 6 o'clock position, just below the nipple of the right breast, not fixed, with no palpable axillary lymph nodes or supraclavicular nodes, and opposite breast is essentially normal. Opposite breast and axilla is normal, sir.
One small question before this, you repeatedly use that word. So, is it below the nipple of the breast, or is it below the nipple areolar complex itself? And how does it matter?
So it is below the nipple areolar complex.
Okay, nipple areolar complex.
Yes, sir.
Okay, right. Right. Proceed.
Okay. So I would like to.
What is the diagnosis?
No mammogram.
Sorry, sir. So
What
my
is the diagnosis?
so my diagnosis is 43-year-old premenopausal lady with lump in the breast. I would like to give a differential diagnosis, sir. I would like to give a differential diagnosis of benign as well as malignant differential diagnosis, sir.
Okay, so what is the first provisional diagnosis?
Sir, since it is increasing in size over the period of 3 months, I would like to go with malignancy, carcinoma breast, sir.
1 second. Because it is now, otherwise, do you have by clinical signs anything to say that it is malignant?
Yes, sir, with the nipple retracted, sir.
Okay.
And
If these two findings are making you think of malignancy,
yes, sir.
how do you rule out these two findings in favor of what benign disease you are thinking?
So it can be
Which
fibrosis.
can grow in 3 months and causing retraction of the nipple. What benign disease you are thinking?
Sir, can be phylloid, sir. 43 years old female.
Phylloids will grow this much is a different story, whether it's benign or malignant.
Yes,
Why
sir.
should there be retraction of the nipple in phylloids?
So there's usually no retraction of the nipple in phylloids. It's until unless the no, sir. There should not be any retraction of nipple in phylloids.
So that finding is against your
Yes, sir. Yes, sir.
And
Yes, sir.
secondly, when you are telling phylloids, it can be malignant phylloids, it can be
Yes,
benign. So, which benign phylloid grows within 3 months this size?
Sir, it will take time for it to grow this big.
So, both what I am trying to say is both
Duration.
what you said, duration as well as nipple retraction,
Yes, sir.
do not favor benign disease.
Benign.
That's why
Yes.
I am coming.
Okay, sir.
Only thing you can probably tell is there is no definite sign of malignancy other than these two. For
Yes.
example, what is the consistency?
So it's hard in consistency.
Hard and consistency.
Yes, sir.
And what is the margin?
Sir, ill-defined margins.
Ill-defined margin. So an ill-defined margin, hard in consistency, occurring in a
Again.
43-year-old, increasing in size by 3 months, and with nipple retraction. Why I should not think as malignancy only?
Yes, sir. We should definitely think of it
No,
as
no. Why did
malignancy.
you give a DD to tell something? See, DD is good if
Yes,
you
sir.
you can say support something with the findings. For the sake of giving DD, then you are in trouble.
Sir,
Now, what you are telling me as a DD phylloides, which you are not able to support with your own findings. So the findings, whatever you are telling,
yes,
are
sir.
in favor of probable malignancy and
Yes,
not
sir.
probable benign.
Yes, sir.
Because there is axilla is free, supraclavicular free, etc., etc. There is no evidence in clinically to say that it has spread, and hence you cannot call malignancy. So you are only looking at lump and lump alone.
Yes, sir.
And with the lump, examination of the lump and the breast, you have to tell the diagnosis in this case. That is why they have called it as early, is it not so? So,
Yes, sir.
when you are presenting 1, 2, 3, 4, 5, and you say, and at the end, and say, with all these findings, that is why Dr. Sarkar asked, what is your clinical or provisional diagnosis? This is a provisional
Yes.
diagnosis.
Yes.
Let us imagine that you are wrong. That is different. But
Yes,
in the clinical findings wise, can any point favor any benign disease you tell?
So just the age, sir.
For 43 years, you can't get malignancy.
No, sir, we definitely can. No, so we can, but only if in case there is any hint indicator of benign condition, just the age. Otherwise, no, sir. It is painless. It is progressively increasing, short duration, sir. And with the examination findings supportive of malignancy, sir, I would adhere to malignancy, sir.
Yeah.
Dr. Sarkar?
Yeah. Iman, what sir has told you, in this particular case, you should not put in any confusing statement regarding the diagnosis. It's very obvious that you are dealing with a breast cancer. Okay.
Yes, yes, sir.
You must close the PD. The PD is very clear. If the
Yes.
examiner asks you what are the possible differentials, then you go into the differentials. But
Okay,
if you
sir.
begin that it can be benign, it can be malignant, that's an open-ended diagnosis. You must have a justification of giving a provisional diagnosis.
Okay, sir.
Now, for the sake of just discussion, can you suggest two differentials, benign conditions? I mean, one or two, just briefly. I tell you, one very common condition is idiopathic granulomatous mastitis.
Mastitis, yes.
It's coming out
Yes, sir.
very strongly, but most of these patients will have a history of pain which is not present in this
Yes,
case.
sir. Yes, sir.
The second is we have
Tuberculosis.
always discussed, but rarely we have found such cases, is traumatic fat necrosis.
Yes, sir.
We have discussed on these platforms, but rarely we find a 3 centimeter lump and we came out with a diagnosis of traumatic fat necrosis. So apart from these two, only realistic differentials can be idiopathic granulomatous mastitis or chronic breast abscess, but pain is an important feature in that. There is usually polyround in most of these patients. Okay?
Yes, sir.
So,
Yes, sir.
or else it's a clear-cut case of breast carcinoma. Okay.
Yes, sir.
So evaluation, how will you evaluate this lady?
Sir, I would like to evaluate this lady on the basis of triple examination, triple score. That is clinical examination, radiological examination, and with a histopathological diagnosis. Sir.
What? Third one is what?
Third one is biopsy, sir. Histopathology. Sir.
I don't understand you.
What biopsy? You tell, sir.
Biopsy from the lump, sir. True cut biopsy from the lump.
So when you
I have a query.
Biopsy is a
I have a query here.
Yes, sir.
Why do you do clinical examination detail like this as we are talking? Why do you want to do radiological examination? Just put a needle. Anyway, lump is palpable.
Sir, only one. There's this triple score, sir. If only one or two is present, does not score over the third, sir. So you have to have all three.
I am very clear in asking question for this patient.
Yes, sir.
Where you got a palpable lump of 3 centimeters.
Yes, sir.
Why you cannot put a needle directly? Something will come out, is it not so? You're telling needle biopsy, and we'll do it straight away. Why
Yes,
you have to do all the other tests now at this point? For example, we'll do a needle now. That comes
Yes.
as malignant cell seen or duct carcinoma, straightforward diagnosis they are giving, let us imagine. Then
Yes,
you
sir.
do all the testing. Why waste your money and time on doing mammogram or radiological examination at this point? Are you catching my question?
Yes, sir. So radiological investigation is preferred before doing needle diagnostic procedure, sir. Because of the
One minute. That is one. And you must tell me why. You are right, but tell me why.
so because there'd be distortion of the image post biopsy, sir.
What distortion of?
Image, sir. The lump would be there'd be discrepancy in the image post biopsy, sir.
No,
False.
you are not getting Sir's question. Sir is asking you, I put it straightforward, the role of mammography in a diagnosed case of, clinically diagnosed case of breast cancer. What is the role of mammogram slash ultrasound in a clinically diagnosed case of breast cancer before proceeding to a core biopsy? That's what Sir is asking you. It's a very simple question.
Sir, to see for multicentric or multifocal diseases, sir, multicentric calcifications, and
One
to
is
see for the opposite breast.
multicentricity and multifocality. What is multicentricity and what is multifocality?
Multicentricity, if it is involving more than one quadrant, sir, and multifocal is multiple lesion in one quadrant itself, sir.
One. What is the next reason?
To see for the opposite breast, sir, contralateral primary, and t- to see for calcifications, some
You told about
diffuse calcifications.
You already told about that.
Okay, sir. And
Size and
size
position
of the
lump.
yes, sir. Size of the lesion and the size of the SOL and the exact position of the SOL in relevance to quadrant, sir.
What else?
Uh,
A very important component of an ultrasound of breast and axilla. What's that?
the axillary lymph nodes, sir. Uh, the BIRADS grading, sir, for the
That is diagnostic.
yes, sir.
What important informations you get from ultrasound of the axilla?
Sir, presence of any pathological lymph nodes, sir. Suspicious pathological lymph nodes.
How do you characterize that in ultrasound?
So the lymph nodes, pathological lymph nodes would be there'd be change in the shape of the lymph nodes. There'd be spheroidal with loss of because of necrosis. There'd be hypoechoic in the center, sir, and there'd be this halo around the lymph nodes, sir, and
There will be a halo or will not be an halo.
sorry, it will not be a halo around the lymph nodes, sir. And increased vascularity of the loss of halo, sorry, and increased vascularity to the lymph nodes, sir.
No. I think you are a bit confused. So initially you remember that the metastasis occurs through the cortex.
Subcortical effacement, sir. Subcortical
First
effacement.
is subcortical effacement and cortical thickening.
Thickening, sir.
Number
Yeah.
2 is loss of hilar fat. Number 3 is change in shape from a reniform to a round form.
Round, sir. Yes.
So these are all information.
Acoustic shadowing, which you already told. And also, most important one, probably all of us are missing, is the size.
Size.
Yeah. Size is an important criteria in any lymph node, okay? Then you
Yes.
go to shape, then you go to acoustic, then you go to cortex, then you go to fatty ileum is there or not. If you
Okay.
go in that order, you will not meet, and this means everywhere. Whether you are
Yes.
going to do the ultrasound in the neck or inguinal region or axilla, lymph
Yes, sir.
nodal characteristics remains the same, okay?
Okay, sir.
Right. Proceed. Please proceed.
So I would like to proceed with a bilateral mammogram sonogram of the breast, sir.
No, 1 minute. 1 minute.
You have
1 minute.
completed triple assessment.
Yes, sir.
No, 1 minute. This question is to Dr. Sarkar and if Dr. NB persons are there.
Yes, sir.
Are we, can we go in this speed or you ask us to finish and take the next case? Is it a time restriction now?
Yes, sir, we have to complete and there is another candidate waiting.
No,
we can...
that I know. Together is there a time limitation? I'm asking. Together, can we take one and then go on like this for the second case, or we have to rush through? That's what I'm asking.
Sir, we have to rush through. The NBMS completes at 8:30. They give us a 5 minutes, 10 minutes space. That's it,
Okay.
sir.
Right. Karen, please.
Yes, sir. After triple assessment, so I would like to go with triple assessment clinical examination, bilateral digital mammogram with sonogram, and this final biopsy, sir.
What type of biopsy you will do there in your place?
So we do image guided true cut biopsy, sir.
True cut biopsy.
Yes, sir.
Why image guidance is required in this case?
So image guidance, sir, because the lump is small in size and also.
What is can be palpable by you 3 centimeter and you are suddenly telling it is small. You pick it up and put a needle. That's all.
Yes, sir.
If you are doing, I'm not telling you should not do. Why
Yes,
you are doing is my question.
So to extract tumor tissue only to reduce the
why
chances of
guidance is required? The question is biopsy you are doing. Why?
Yeah, sir. For this patient, the guidance can be used with simultaneous localization of the tumor if the patient is going for new adjuvant or if in case the patient has been planned for breast conserving surgery, sir.
Everywhere ultrasound guidance is not required. Number one.
Yes,
number two, if we are doing it, there must be some reason. In general, thumb rule is what? When you do an imaging, you want to hit the right place.
Right place.
Not
yes,
do
sir.
a geographical mix.
Yes, sir.
Yes,
Geographical mix. Yes, yes, sir.
So that is the second one. All this holds good, particularly when they are dealing with the larger lumps where you are expecting necrosis in some areas. There will be positive areas, etc. Yes, when a lump of this size, 3 centimeters, you don't expect that to occur.
Yes, sir.
But in spite of that, if you are doing, you should be able to defend yourself. Sir, I want to accurately do it,
sir.
And I want to place something. If you want, you are started telling that, place it in the center. All this, if you are going to tell, then you are justified in saying, I'll get a guidance and do. Otherwise, a lump of this size, you can do.
Yes, sir. Yes, sir.
You can put an incision
Blind
in
biopsies,
the
yes, sir.
middle, and you can place your needles and core when you are taking in multiple directions. You can take.
Yes,
you
sir.
got what I'm telling?
Yes, sir. Yes, sir.
Right. Next, because I have to take the next case they have told. Next.
So histopathology on the biopsy came out to be invasive lobular carcinoma, and immunohistochemistry for ERPR status and HER2 status showed it was hormone receptor positive, it was HER2 negative, and a Ki67.
1 minute. It is interesting to know it is lobular. Will you go back to your mammogram and put it?
Yes, sir.
Yeah. Now tell me, where is the lesion here?
Sir, my pointer is not working, sir, but
you are able to see pointer.
Yes, sir.
You are
yes,
able
sir.
to see.
Yes,
And what
sir.
is the standard teaching as far as mammogram and lobular carcinoma is concerned?
Sir, mammogram usually there in lobular carcinomas there's no calcifications. Usually
lobular carcinoma can be missed in the
yes, sir.
Point.
Yes, sir.
Okay, that is the point. That's why I asked. Now that you showed me lobular carcinoma, I just wanted to know whether can you zoom it at least if you are not able to show the markers, but you can zoom.
Yes, sir.
Are you understanding what I am actually asking for?
Yes, sir. Right. So I've zoomed the image, sir.
Yeah, I'm seeing.
Okay, sir.
The other one? Other image. Right. Carry on.
Sir, I think it's quite a dense breast. Do you
Yes,
have
sir.
an ultrasound? Do you have an ultrasound?
Yes, sir, I do, sir.
Show us the ultrasound.
So ultrasound images I don't have, so I just have the report, sir.
Okay. It's quite a dense breast.
Yes, sir.
So, yes, that again is a risk factor, isn't it?
Yes, sir. Yes, sir. Increased dense breast, ACR grade C disease, sir, and increased density of the breast is a risk factor for malignancy, sir.
Okay. Sir, do we close her because
Yeah.
or
I think
else
so.
what if Som is there, we can complete this case and take LABC. It will be, 10 minutes we cannot complete an LABC. Is
True,
Som
true.
there? Then
That's
we
why
will,
I suddenly asked that question. If we are giving so much importance in this first case, then push through. We are not doing justice either to the case or to the candidate.
exactly, sir.
Please carry on, sir.
Thank you.
Okay. So what's your are you going to do a metastatic workup in this particular lady?
Sir, I would just get a chest X-ray and ultrasound abdomen, sir. I would not do an extensive metastatic workup.
Which guideline states that chest X and ultrasound actually helps in staging?
So,
Either you stage or you don't stage.
no staging, sir, for this patient, sir. No staging for this patient.
Yeah, so no confusions. You at best can do a liver function test and get away with an alkaline phosphatase. If it's elevated, you can think of doing. Then you can think of doing either an abdominal CT or a bone scan.
Bone scan, yes,
But
sir.
generally, less than 5 centimeters with oligometastatic or non-metastatic axilla, you would not go for a staging. Okay.
Yes, sir.
So, what is your treatment plan for this particular lady?
Sir, after assessing her, I'll counsel the patient about the disease. I'll give her.
All formalities taken care
Yes,
of.
sir. Yes, sir.
Now you tell us what would be your option for treatment in this particular lady.
Sir, I would like to go for a breast conserving surgery for this patient, oncoplastic breast conserving surgery, sir.
Okay. So if you are planning to do a breast conservation and oncoplasty in this particular patient, tell us how do you plan the surgery?
Sir, we first the planning of the
What
surgery
type of
depends upon the.
OPS? What OPS you are going to plan for a patient who has got a central neck lesion?
Sir, I would like to go for a central basic technique, central breast conserving surgery, where I'd remove the nipple areola complex and the tumor. Or if I wish to preserve the nipple areola complex, then I would go for central compartments. I would like to go for a donut mastopexy or inverted T incision, or sir, I would like to do Batwing's mammoplasty, sir.
No, hold on, Rumani.
Yes, sir.
I don't understand how will you do it's central neck lesion,
Yes, sir.
and so how will you do that? Wise pattern or whatever you are stating.
Yes,
what
sir.
would be the best option for a neck lesion?
So, for the neck lesion, the best option would be, sir, central quadrant excision, sir.
We know that, but you told you were going to do an OPS.
Yes,
what
sir.
OPS will you choose?
Sir, I would like to go for a type 2 oncoplastic surgery, sir.
I agree, but what type 2 oncoplasty? The best option here would be, if it's a central quadrantic lesion, it has to be a Grissotti flap.
Grissotis, yes, sir. Grissotis, yes, sir.
But what are your concerns in this particular patient? Looking at the mammogram, where you don't really have a margin, a very clear-cut margin or a lesion which is visible in mammogram, what are your special concerns in this particular patient?
Sir, since the lesion is not very well defined, there'd be high chances of positive margins, sir. And
So what will
inadequate localization of the localization. So I would like to get a post excision of the lesion tumor. I would like to confirm whether the tumor is adequately sized by doing a frozen section on table, sir.
So you are going to do a perioperative margin assessment, is it?
Yes, sir. Yes, sir.
What are the different ways of perioperative margin assessment?
So we can do specimen mammogram, sir, and we can do specimen if there is a frozen section, and if there's no frozen section, we can do sir imprint cytology and radiogram of frozen the mammogram of the breast specimen that is excised, or we can do cavity shaving if nothing else works. Sir.
Okay, so there are three methods, as you rightly said. One is the frozen, number two, a specimen mammogram, and now there is a special technique called plexitron. That's a perioperative radiological assessment. There is a which mostly not available in India now. Okay,
Okay, sir. Okay,
what
sir.
will be your option for axilla in this particular lady?
Before you answer this question, you won't think of an option of mastectomy at all in this case, just because of its location, and it is because it is lobular. Two questions here.
So I can consider.
I'm not
can.
telling you don't do breast conservation. That is not my point. I'm just asking, is there an option of mastectomy to be given to this patient because
Yes,
of its location? And will you even think, or what is your idea about doing a mastectomy versus breast conservation in a lobular carcinoma?
Sir, lobular carcinomas are usually multicentric. So there's a possibility that if this has manifested, there'll be a possibility of recurrence later. So I'd like to go for mastectomy if mastectomy would be because of multicentricity and
No. Please, I am asking
bilateral.
a question. I am asking a different question. I'll change my question. Now, I'll reword my question.
Yes, sir.
Just because it is lobular carcinoma, is there any contraindication of doing breast conserving surgery? Or you will do mastectomy only just because it is lobular carcinoma? That is the point I'm asking.
So lobular carcinoma carries a good prognosis, and it is for mastectomy only if it is a lobular carcinoma tends to be multicentric. So that's why I would like to.
How will you know multicentricity when you have already discussed that we have not picked up by the mammogram anything?
Yes, sir. Yes, sir.
How did you now? How will you prove or approve otherwise? Whether it is normal or rest of the breast is normal or otherwise, how will you prove in a lobular carcinoma when you know that you can't prove even the lump?
Yes, sir.
That is the point.
Yes, sir.
So, what is the current thinking? I'll tell you the other way.
Yes.
Lobular carcinoma was considered to be multicentric, and so we used to do mastectomy only.
Yes, sir.
Conventionally.
Yes, sir.
Now I am asking, and when they brought breast conserving surgery, lobular carcinoma was considered as a relative contraindication when it started breast conserving surgery. So, what is the current thought about that? That's all my question is. Whether otherwise it is you are able to do a breast conservation, let us imagine.
Yes, sir.
Whether this histopathology will dictate now converting that into mastectomy.
Sir, I would so these are I can still go for breast conservation surgery because these are ER positive, hormone positive tumors usually. So adjuvant endocrine therapy would help in reducing the chances of recurrences. So I would consider going with.
Iman, you are not understanding sir's question. Sir's question is lobular carcinoma a contraindication for breast conservation surgery?
No, sir.
That's what sir is asking you. Okay.
So, on one histopathology diagnosis of lobular, you will not change your thinking now. Why I brought it, I told you.
Yes, sir.
When breast conserving surgery, when it came in, lobular carcinoma alone was considered histopathologically was considered as a contraindication, at least a relative contraindication, and they gave explanation, etc. That is why I said, what is your current thinking? Fine.
Yeah.
Now coming to the axilla, you tell the axilla. What do you do?
So I would like to go for sentinel lymph node biopsy if I'm going with breast conservation surgery, sir. And since it is a node negatively, clinically node negative, sir.
Okay. What technique will you choose for sentinel lymph node biopsy? What are the different options available at present? 1, 2, 3. Just give the options.
So the available options are isosulfan blue dye, sulfur colloid injections, and indocyanine green, sir.
Good.
All these things are dyes, correct?
Yes, sir.
Dyes, correct?
Yes, sir.
So you do only dye technique or anything else you can use?
Technetium liberal sulfur colloids, sir, for radioactive tracer.
Yeah. Will you do both or will you do only one?
Both, sir, has better sensitivity, sir. Both.
What, sir? 97 is not big number, sir. You should have given me at least. Yeah, but you should have given me 60 or 70. I would be happy.
Okay. So, what would be your option for,
Sorry.
the adjuvant therapy in this particular patient? Its sentinel lymph node biopsy is negative. It's 2.5 cross 2 centimeter lobular carcinoma, ER positive, PR positive, Hartinium negative, Chi 67, 25%. That's what you told. Your
Yes.
kind of breast conservation, the margin is free. Give us the
Yes.
options for adjuvant therapy.
Sir, whole breast radiation, post breast conservation, sir, whole breast radiation therapy with adjuvant endocrine therapy, since she's hormone receptor positive and more than 2 centimeters, so would go for an adjuvant chemotherapy, sir.
Oh, more than 2 centimeter. Do you think that size is the only criteria to re-stratify the use of chemotherapy?
No, sir, other high risk features as well, sir.
What are those high risk features?
Sir, the grade of the tumor, the presence of nodal metastasis, the presence of LVI, sir.
The ER status?
ER status
age of
for
the
adjuvant
patient?
endocrine. Yes, sir.
Okay.
Yes, sir.
So, what are the newer prognostic markers available to choose systemic therapy in early breast cancer, node negative, ER positive cancers?
Sir, if ERPR positive, node negative, and cancers, we can go for oncotype DXPO to assess if the patient is having low, moderate, or high risk for recurrence later, sir.
Okay.
What is the idea? What is the idea of doing this at this point? What is one single line idea I want? What are we trying to do by doing oncotype DS when otherwise clinical and pathological pointers are showing that it is rather early?
So risk of recurrence later, sir.
No. Is that the reason we are trying to do?
Right.
So okay, risk of recurrence, you take it. How that is going to help you? What are you trying to do?
Choose for adjuvant therapy, adjuvant chemo if required.
Whether chemotherapy can be avoided is the question.
Yes, sir. Yes.
Okay.
Yes, sir.
If you have decided to give chemotherapy,
yes,
then why do all this? Not required, correct?
Yes, sir.
In such an early disease, we want to know whether it is really required to give chemo or can we avoid.
Yes, sir.
This question comes to you, then you are going to do oncotype DS, all right?
Yes, sir.
Yeah, tell me.
Sir, I think we are exceeding the time.
Yeah.
Dipten and Vijaykumar sir, what we will do is we'll complete this case. LABC will post on another day. It's fair actually, right? So
correct.
Because discussion is
correct.
going well and there are a lot of questions also. So you can complete this case, answer all the questions of the students. LABC mutually I'll check with both of you in August month and I'll do Ashish will present that day. So it's fair. The discussion is going in a flow. It is helping students.
Thank you, Samshekhar. That's what I meant because it's not fair on our part to just rush through the second. Thank you. Yeah, continue, man. Now that you have, what will you give now? You have decided to give chemo, let us imagine. What will you give in your setting? What are the options and what do you do?
Sir, if she falls into low risk, I would avoid, according to oncotype DX score, I would like to avoid chemotherapy for this patient and give her only whole breast radiation therapy and followed by endocrine therapy, sir.
What endocrine therapy you will give here? Premenopausal?
So I would like to give her tamoxifen 10 mg for 10 years, sir. And then once she attains menopause, I can shift to anastrozole, sir.
Is there any role of oophorectomy?
Aromatase. Uh,
Because you have
yes,
decided.
sir. Ovarian suppression. Yes, sir.
What is
If
the
she
role
has
of,
complete.
what is the role of oophorectomy in this setting when you are decided to skip chemo but give only endocrine therapy? What is the idea and what is the evidence? First, we'll have to have some basis for what this question is being asked.
So, since it is hormone receptor positive, oophorectomy will help in estrogen suppression, sir. Because there'd be no estrogen production, then the chances of recurrence later on in life would be reduced, sir.
Right. Is it a done procedure nowadays? Electro-oophorectomy for a non-metastatic disease, early disease. What I am
Yes, sir.
asking is, you said endocrine therapy. Endocrine therapy, you said, what did you say? Anti-estrogen, right?
Yes, sir.
What anti-estrogen you use?
So, tamoxifen, sir.
Okay. And you said tamoxifen for so many years and then switch over. Fine.
Yes, sir.
Is there a necessity in this setting? Is there an evidence to say by adding oophorectomy to tamoxifen, will it be useful anyway?
So, since it is hormone positive, so I don't know.
No, hormone
I don't
positive,
know,
you have decided to do endocrine therapy, all are fine. I am asking a simple question. Whether it is tamoxifen alone or is there any role of introducing oophorectomy, will it help the patient in this setting? Dr. Sarkar, you can help her.
Yeah, so Sir is asking you, in this particular patient who is ER2 positive, HER2 negative, Chi67 is 20%, there is no sentinel lymph node biopsy, so the margins are free. Is there any role of surgical/medical oophorectomy?
No, sir.
In which, so how will you benefit by doing a surgical/medical oophorectomy?
So, medical oophorectomy by giving her anti-estrogens and surgical by salping oophorectomy, sir. But
No, one minute. Medical
sorry.
oophorectomy is what you said?
Sorry,
No.
not medical. So
He said options. Surgical oophorectomy, I know you will know. Remove ovaries, that's fine. But medical oophorectomy is what?
So gonadotropin suppressors, sir, not anti-estrogen, sir. Sorry.
Yeah. So see, you cannot make these basic mistakes. Suddenly,
Yes, sir. Yes, sir.
Sir would actually, that's a knee-jerk reaction will always happen.
Yeah. Yes, sir.
Okay, so you can choose to upgrade to not in low risk patient but in high risk
categories.
Or you have a metastatic breast cancer, you can upgrade to a surgical slash or medical oophorectomy, and the advantage would be you have a large plethora of available adjuvants when the
Yes.
patient is postmenopausal. When
Yes,
you
sir.
choose that postmenopausal would be an advantage to you, you can opt. But if it's a low risk patient, you continue with tamoxifen. That's a good enough drug, a time tested drug with a good amount of risk reduction.
Okay.
What about now? You told that you are going to do a breast conservation. Now, can you tell us about newer innovations in radiation? Just one or two, and then I think we can call it a day.
Sir, accelerated partial breast irradiation, sir.
Okay, one, and the second one, which is a new innovation. Can you name about that? Was started by an Indian by.
Yeah. Dr. Jayant Vaidya by name.
No, sir, I am not aware, sir.
So
Actually,
yeah, KK writes intraoperative brachytherapy. Yes.
intraoperative back. Yeah, sorry, sir. Sorry, sir. Yeah, I failed to recollect. Sorry, sir. Yes.
Sir, I think we should close it here because yes, generally performed. I mean, from my point of view, Rumani, your performance was good, except certain areas where you have knee-jerk the answers.
Yes, sir.
Like when you were telling about the clinical examination, if you forget to mention supraclavicular lymph node examination, that is something which will not satisfy an examiner. You
Yes,
cannot tell it, I mentioned it in the general survey. Okay.
Yes, sir. Yes, sir.
So when you are giving a diagnosis, you must give a clear-cut diagnosis. You cannot tell, I would offer a differential, it can be benign or it can be malignant. Differentials come later on. You have to give a diagnosis. Okay?
Yes, sir. Yes, sir.
When you are asked what is the role of mammogram, you must straightforward state 1, 2, 3, 4, 5. These are the reasons for. So you cannot give a vague answer to these questions.
Yes,
Apart from that, you have just taken your singles quite nicely, and I congratulate you for your presentation.
Thank you so much, sir.
Over to Dr. Somsekhar.
Thank you. Can you just open a chat box and Q&A? There are some questions, so we'll complete in next 5 minutes. And Ashish, your case will be scheduled in August, okay, because the calendar is already fixed. My apologies. I'll check with Dr. Professor Vijaykumar sir and Dipte. If 13th August Saturday, if they both are free, then you present LABC to both of them. 13th August, I'll check with both of them. Huh? Ashish, okay?
Yes, sir. Thank
13th is ABSI. You are the president.
Yeah, but teaching program has to go ahead. Means, we have never stopped. Even when I was in US, I did stop. Morning 1 hour, I will do it.
Okay, no issues. I can do it from Hyderabad, no issues.
No problem. It's online. So we do. Even when I was in American College of Society giving oration that day morning also I did teaching.
No issues. 7:30.
Just 1 hour. Yeah, only LABC this boy has taken. It's a very good thing.
Correct. It's our moral responsibility. You should
Thank you, sir. Thank you very much for this.
shrug away.
Ashish,
Also,
really.
I don't know whether Somsekhar and Sarkar accept it, but I thought this is an educative session, so I didn't want to cut short. We could have easily finished in half an hour slot. We could have given, but we would not have done justice, is what I feel, because it is more of an education, educating everybody, not only the candidate who was presenting, and hence we went that way. I only hope National Board and Somsekhar do not take it.
No, sir. And the flow you took was very good, sir. The flow. Ultimately, students should get that approach flow systematically. So you are taking so well. Thank you very much. You are absolutely right. It's unfair to candidate students. So, Dipten, can you open the chat box and Q&A and answer them? Yeah.
I think there are mostly comments. Number one, Dhara Pandya writes, "Sir, IVF is a risk factor for breast cancer." The answer to the question is, if there is strong familial predisposition, then yes, it is a risk factors. Okay, but suppose it's there is no strong familial predisposition in a general population, it does not increase the risk. Number two, you have already mentioned about the soft and the text trial. So the next question is, MRI in this case as HP is invasive? Yes. Rakesh, we accept, as Sir has already told and I also told, and she also mentioned that in this particular patient, it's not very obvious about the margins in mammogram. She was unable to show us the ultrasound. Clinically also, I think it was a bit infiltrative. If somebody performs an MRI, I won't disagree. But routinely, MRI is not indicated, at least in palpable breast cancers. Okay? Sir, what's your take on MRI in invasive lobular cancers?
No, you already told. I fully agree. Otherwise, I would have jumped. Don't worry.
Thank you. Well, Dharia Pandya writes, fast forward. I'm sure that's not the name of a trial. Or are you asking the examiners to be a bit faster? Thank you, Dharia, for reminding us the issue of time.
And Daria, go and read target trial, okay, A and B, what they were telling. Please read about target A, target B trial.
Yeah. I think abortion and MTP sir has already told about the risk factors when he had discussed it. So I think that's mostly the questions. Any further questions, sir, will be too happy to answer your question. I can tell you, meeting Dr. Vijaykumar is such a big thing. You are honored, we all are blessed that you are able to reach him directly and ask questions.
And then I have to tell you, when I gave my MCH exam in GCRI, Sir was my examiner. For 2 hours, he grilled me on a CA breast case, and at the end of it, he gave 99% out of 100, but 2 hours from basic to translation. So whenever I have a breast oral cavity, I first check with sir, because treasure of knowledge in him is so vast. Rather than hearing from us teacher, you have to listen from teachers of teachers. So sir always says yes. If I give 3 hours, if you listen to him alone, you don't have to listen to anybody. I even now I remember my exam sir has taken, and I really learned more in that exam than reading Devita 100 times. So that's
So,
why I also
Dr. Somsekhar, I think it's time for me to leave, I think. Right, thank you. Thank you very much. Thank you. Thank you.
Thank you,
Thank you
students.
very much,
It
Dr.
has been
Rumani.
very good. Yeah, it has been very good. And August, I will request both examiner and Ashish will present LABC. So over to you, Navneet Singh ji. My heartfelt thanks to Dipten and Vijaykumar sir. Beautiful discussion. As I always tell you, remember, they showed how the question comes, they stimulate your brain, and they show a path, you have to walk it. So the concept has been given. This is how in exam it happens, and get the concepts right, answer rightly, don't dig your grave. Examiners are always helping you, giving some subtle tips. Vijay Kumar sir is giving such a tip and then she is not getting it.
Yes.
So you must have that intelligence of understanding. Examiner is always helping you. Please understand, when you're on wrong path, you catch their tone and then try to do course correction. Thank you. Over to you, Navneet Singh ji.
Anyway, all the best, Dr. Rumani.
Thank you, sir. Thank you so much, sir.
Well, thanks
Thank
to
you very much, Dr. Rumani, for the presentation, and thank you very much, Professor Dr. Diptendra Sarkar, Professor Dr. Vijaykumar, and Professor Dr. Somashekar for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.
Thank you, sir.